Okay, I think we should be good to start. All right. All right, is that better? Perfect. The system, it seems easy, but it's really not that easy. I think I'll have to come up with a tutorial, I think, to teach everyone how to do it. But there's a lot of mutes and unmutes that you need to do to get it to work. So anyway, welcome to all of you. This is our Journal Watch conference. This is actually the first one for the year. The one in July got barreled, as we say. But so this will be our first Journal Watch. So this really is a relatively new conference. We just started this about a year ago, but the main purpose is discuss notable journals in the different specialties and identify some methods on how to stay relevant. Conferences, so any of you who decide to go to a conference, definitely it's a great experience. We only ask that you come back and share your experience with everyone else. So today we are fortunate that we have a few residents who went to the endocrinology conference in Boston who are going to share their experience, and then Iman, who went to ASCO, American Society of Clinical Oncology in Chicago, and she'll share what she learned. And our faculty expert for today is Dr. Garnapudi. So when he comes, we'll just have him kind of talk a little bit more about how he stays abreast with the literature. So with that, let's go ahead and get started. So as always, put away laptops and cell phones. The conference, since this is the first one, I like to just do this at the beginning of the year, just so that you all kind of know the purpose of this conference. And definitely, if any of you want to present at this conference, let's say there's something you learned that you just want to share with everyone, or a late-breaking trial, feel free to email me. We do this once a month. The whole purpose is, when you do Journal Club, you only are picking one article to go through, but when you do this Journal Watch, you may pick 2 or 3 articles and quickly run through them. So whatever was published in the last couple of months that you think is relevant to your colleagues, this is the forum to present it. So really, I think all of you probably know this. Any of you who go online, you realize that there's a ton of stuff out there. I mean, there is every single day, there's new articles being published. If you go on, there's podcasts, there's Med Twitter, I don't know if there's Med Instagram. Is there Med Instagram? But Med Twitter is there's so much information out there. Really, it's hard to stay abreast. And I think the days of even me, and definitely probably Dr. J, I used to have stacks of journals, and I still get like 4 or 5 journals every month that come to my home. And so we all have these stacks of journals, and that's really, compounding the whole issue is that there's too much information out there. It's a very important skill for all of you to learn what to follow and how to follow, so that way you can stay relevant. So with that, these are different strategies. I obviously don't expect you to do everything, but I think the most important is to figure out how you learn. So very important to learn whether you learn by visual, whether you learn by auditory. Most people, 30% of people learn both different ways. Are you someone who enjoys going to conference and seeing things and being part of that experience? And again, there's no right way to do it, but the point is really figure out which way you learn best so that you can retain the material. So journal surveillance, I hope all of you know how to do this. And again, if you don't know how to do any of this, it's totally fine. Come find me, Toon Me, Zuhair Ali. We're the people who can really help, and many of your co-residents can help. But subscribe to E-Table of Contents. If you want to be a cardiologist, I really hope that you've already subscribed to the E-Table of Contents for the ACC or AHA or Circulation, some of the big journals in that field. If you want to be a nephrologist, ASN has a couple of big journals, HAKD, but it's free to go and subscribe to the Table of Contents. Every month, they will email you what they're publishing, and all you have to do is click on the button to read it. So definitely, you should definitely do that for everyone. Alerts from PubMed, if you go into PubMed and log in, let's say you have a specific, so in my prior life, my main area of research was in access to dialysis for disparate populations, like undocumented patients. So I had a whole alert within PubMed that anytime someone published on that field, it showed up, no matter what journal it was in, it showed up in my email, and I could sift through it. So if you really want to be a content expert on something, which maybe you're going to develop over the next 3 years, that's something to start doing. Podcasts. If you don't listen to podcasts, I highly recommend it. There are a lot of them are free out there. Curbsiders, Core IM. I have the 30-minute drive every day, so at least 1 or 2 days a week, I put a podcast and listen to it. There's really great stuff, and again, we're doing the podcast series to help kind of really alert you to some of the high-yield one. Conferences, we'll talk more about social media, newsletters, and so on and so forth. Manuscripts, editorial. I think Hamza is still on the editorial board for the HCA Journal of Medicine, so definitely if you have interest in being an editorial member, often those are more for faculty level, but some boards have resident members and some journals have resident members in different sections. And then presenting. As I always say, you learn best when you present it. So take advantage of opportunities to come and present to your colleagues, because I promise you're going to learn everything a lot better when you're standing up here and teaching it to your colleagues. Visual abstracts, most of the top articles published will also have an accompanying visual abstract. So if you don't want to read through everything, and I don't blame you, just look at the visual abstract. You can look right here, just looking at this picture. It's got someone with a mask on one side, without a mask on the other. And the whole study was, this is a trial for 14 days, looking at whether people who wore a mask or not wear a mask had felt better about self-reported symptoms of like upper respiratory tract infections. So down at the bottom, you can see those who wore a mask, about 9%. And the odds ratio, again, the forest plot shows that the odd ratio is, the dot is less than 1. So the confidence interval doesn't cross 1, so statistically significant. So if you feel inclined that you're going to develop a URI, maybe you want to wear a mask and you're going to feel a little bit better about the symptoms that you have with respiratory tract infection. So visual abstracts are definitely helpful. New England Journal, I think all of you really should subscribe at least to the e-table of contents. New England Journal of Medicine is really the pillar in internal medicine and generally for all medicine, but internal medicine is a great one to subscribe to. Depending on what you like to look through, perspectives, I think as I've gotten older, perspectives tend to be my most favorite section. They're usually short editorials. So they're not really editorials, but short papers. May talk about like climate change and healthcare, or someone writing a story about an experience with a patient. Review articles are really helpful. I think for all of you, when you see a patient in the hospital or in the clinic and you want to know, histoplasmosis, how does it occur? What happens? Go into the NEJM website. You can just type it in the search. And I'm sure there's a review article sometime in the last 10 years on whatever topic you want. Case records are CPC style, so definitely if you, Question?
New England Journal of Medicine is a part of it here, right?
Yes. Yeah, definitely that. CPC style presentations are great when you're preparing for conferences or you want to prepare a case report. Just look at how they write it. They write it in such a format that's very succinct. They don't put all this extra details. It's just very much to the point. It teaches you really clinical reasoning skills. And then editorials, anytime, like for those of you who are doing journal club, definitely always look at the editorial, because editorials are often invited by an expert in the field. And so they're writing about the article that you're choosing to present. These are so within the NEJM, again, you can see at the top, it's HCA Clinical, and I'll show you how to get to it. But you can even search depending on what you're interested in. So if you want to be an oncologist or you want to look at oncology, you can just search and see what's the latest things published over like the last 40 years in that field. Annals of Internal Medicine, again, all of you have access to this, not just with HCA, but just as members of ACP, which all residents are members of ACP. So definitely log into ACP. You can specifically log into Annals of Internal Medicine and choose what you want mailed to you. You can have just the table of contents every month mailed to you, or you can have just a listing of different articles relevant to your fields that's sent to you. So they have all these different options. Educators option, fresh look, careers even. So as you start to think about what you want to do. So definitely this is another great resource to have. And I think for all of you, at least if you're going to pick one journal to read cover to cover, as residents, this is the one to read. This just shows what comes in my inbox. At least once a month I get this. It just shows all the reviews. And then from here, you can just click and read what interests you into your field. The in the clinic section, this one again is part of our clinic didactic. So Monday afternoons, when you're in the clinic week, you're going to be doing didactic sessions, but at least one of you will be assigned in the clinic didactic. So in the clinic is the last section, typically in the Annals of Internal Medicine, very much clinically relevant. It's meant to be in the outpatient setting, focuses on practice management for common conditions, so on and so forth. So for example, preoperative evaluation for non-cardiac surgery, evaluation of the patient with abdominal pain, gastroesophageal reflux disease. So just very kind of bread and butter things, evidence-based. They're published, every month, an update. Again, as I said, if you want to look back, there's some really great ones published in the past to keep. So here's a list of just the last, 5, 10 ones that came out. So very much geared towards how you think and how you approach someone with abnormal CBC or abnormal LFT. So really a great resource to have. And then our GME site, if you guys are not familiar with this, definitely bookmark this, triple bookmark it. It's a really great resource. This is how you can access the library. So if you look down at the bottom, here you can have library access. This is also where you can see all of our symposium stuff. So from last year's April symposium, you can look at all the abstracts, you can look at all the posters that were presented there. But once you click on this website, basically it'll take you directly to, and it's automatically, if you do it on the network, it'll automatically know who you are. There's no login that's required. And you can just search on here for what journal you want and get access to it right away. So really a great resource. No excuse really not to be able to access any journal you want when you're here. Then the last thing I have before I turn it over to Renu is and Basit is one of the probably most seminal articles that was published in the last month. I just want to share with you the effects of semaglutide on CKD in patients with type 2 diabetes. So this was published July 11th in the New England Journal of Medicine, also called the FLOW trial. Pretty much a landmark article, and I don't think we're discussing it for the Nephrology Journal Club this month, so I wanted to show you guys. Basically, as you know, when you have someone had CKD, you only have two outcomes that you're looking at. One is you want to slow the progression by reducing albuminuria. So anytime you see them in clinic, is their proteinuria less than it was before? Or two, are you slowing the slope of progression of eGFR? So if the eGFR was 50 before, ideally when they come back, you want it to be as close to 50 as possible. If it goes down to 40, it means they've had a significant drop in eGFR. So I think we're all very familiar for the last 40 years, ACE inhibitors, ARBs, which are called renin-angiotensin-aldosterone system inhibitors, kind of been standard of care. The last 5 years, SGLT2s have really taken over, and there's been some big trials, DAPA-CKD, EMPA-CKD, have looked at SGLT2 inhibitors both in diabetic and non-diabetic patients with CKD. And when I say non-diabetic, including patients with IgA, patients with lupus, patients with hypertension and kidney disease, so all different kinds, have found those to be very effective. Non-steroidal mineralocorticoid receptor antagonists, so finerenone, which is in the same class as eplerenone or spironolactone, has been proven for diabetic kidney disease. So really, I think all of us are very familiar with semaglutide as blockbuster drug, weight loss, type 2 diabetes. So the question really in this study was, is there benefit compared to placebo of using this drug by itself to slow the progression of kidney disease? Now, prior to this, in the early 2010s, there was SUSTAIN and AWARD-7 were big trials, cardiovascular trials using GLP-1 receptor agonists, and found them to have secondary endpoint was kidney disease and found it to be benefit. But this is the first trial where the primary endpoint is kidney disease progression. So again, trials, secondary endpoints are all hypothesis generating. So if secondary endpoint shows something, it doesn't mean it's necessarily true, it's just kind of a finding. Whereas when you go back and power the trial for a primary endpoint like CKD progression, that's where you can actually get FDA approval for it. So just looking at this, I think the big question is, as you can see, 90% of patients were on ACE or ARB in both the placebo or the semaglutide. Only 15% of both patients, patients in both arms are on SGLT2. Probably that's similar to how it is now. I mean, the cost of SGLT2 inhibitors and access to care is still the big barrier, but certainly you would have expected to be a little bit higher given that they are standard of care. You can see that the separation occurred within 12 months and definitely persisted all the way through. So the first major kidney disease event, so at 4 years outcome, you can see patients on semaglutide had a lower incidence of either decline in albuminuria or eGFR slope. And then again, as we pointed earlier, the forest plot, again, you like to see it all towards the left, and especially with the confidence intervals not crossing 1, that means it's statistically significant. And you can see the number of 0.76 really means a 24% reduction in events for patients who are on semaglutide compared to placebo. So this is really probably going to change our practice a little bit. So when you have patients with diabetic kidney disease, you can say compared to placebo, putting them on this medicine may actually slow the progression of kidney disease. So definitely a big article for us in nephrology. So last is, what do you want to read? Again, read what interests you, but you must read what's relevant. So I think for first years, I expect all of you to be reading Annals of Internal Medicine. You should be getting a paper copy. If you don't get a paper copy, I'll show you how to get a paper copy if you want one, but at the very least, you can get it electronically. It takes about an hour to read cover to cover. If you know what you want to do when you grow up, so to speak, start subscribing to some of those e-table of contents so you can stay relevant, because of course, you know, residency is really just kind of preparing you for what you want to do in practice. And then plan your calendar around 1 or 2 conferences. Definitely, anytime you go to conference, please submit an abstract. If you're going to go there and sit there, you may as well present some research while you're there. So don't go there empty-handed. Of course, if you don't get accepted, that's one thing, but at least try and get something presented at a conference. And I think that I'll turn it over to endocrinology.
Hey guys, so I'm Renu Thomas. I'm a PGY3, and here's Basit. He's also a PGY3. We've both applied for endocrinology this year, and we got a chance to go to Boston in June, and we're here to present what we learned there. Okay, so why endocrinology? I came in interested in wanting to do endocrinology, so Dr. Raghavan put me in a pathway early on itself. So since intern year, I've been working with my mentor. So I was fortunate enough to get some good publications in. So there are 3 main conferences. The main one is the Endocrine Society. There's the American Diabetes, and there's the American Thyroid. And if you're all interested, please do come find us. There's only 8,900 endocrinologists in the whole nations, and so there's a great opportunity. There's a lot of jobs out there that needs to be filled. It was a 4-day conference. It was in Boston. There were several breakout sessions, not just science, but there were so many opportunities for career development. We could meet a lot of fellows who are currently in programs in different parts of the country. So there was a lot of networking. There was also very career development, personal development, public speaking, and there are so many sessions we could all choose from and go and attend. There was also the poster expo, and there were several debates that we found very interesting. The one that we all attended was combination T4, T3 therapy, or just T4. As we all know, it's just T4 that we normally do, but there are a lot of endocrinologists who practice combination therapy because they think it helps patients with symptoms. But interestingly, most of those endocrinologists were from outside the US, where they have more controlled combination therapy, especially in Australia and the UK. They do have more combined therapies which are patented and much safer than the ones that are available here in the US. So a lot of the people thought combining them was really good in helping overall with the symptoms. And some patients actually preferred the combination therapy, but most doctors or the endocrinologists practicing in the US, they still prefer just the levothyroxine. So this was an interesting debate. Now there's, as you all know, more cardiovascular clinics are incorporating an endocrinologist in their practice. The main thing is treating endocrinology conditions has that anything to do with cardiovascular benefits? Correct me if I'm wrong. Currently, there are no guidelines which says that you have to treat a TSH of 3.6 or a normal TSH, as you all see here, just because they have other coexisting cardiovascular conditions. But maybe in future, it might come to a point where if you have more cardiovascular risk, or if you have a high ASCVD score, treating a thyroid might become the clinical practice. So that was something we learned. Another thing that we really were interested in addressing social determinants in routine diabetes care. So we had several sessions from Harvard Medical School. There was this doctor who's specializing in making sure the insulin affordability and making sure patients not just had medications, but had good access to good food. So what he essentially did was, if you see on that chart there, he actually sent volunteers to go with the patients and shop at different supermarkets and kind of compared what they chose in terms of their calories, what kind of foods they picked from the grocery stores, and kind of streamline and tell them what exactly was a good diet. And it's in a bigger setting where there's more funding, all that's very practical. But based on that, he kind of came up with the questionnaire on the side. Basically, do they have access? Do they have transportation to go and get their medical appointments. Do they have access to their medications? And what's your housing situation? Do you have a car? Do you have trouble paying your bills? And, pretty much all the basic socioeconomic questionnaire points that were asked. We're actually currently working with TUMI and trying to see if we can get a QI project out of this. If anyone's interested, please come find me. There are actually a few residents already interested. So I think we have room for one more person, kind of making this for our clinic, or if we can make like a questionnaire for our clinic, which we can use it with every patient and come up with how their socioeconomic status is kind of influencing how they're going through. And then we can get a lot of research out of it as well. Another interesting thing, this is a scoring system. It's on MDCalc. I've never heard of this before. MASLD is becoming very popular nowadays, and it's going to become a thing among the endocrinologists where more endocrinologists are going to do fibro scans in clinic, where we can actually kind of monitor their fibrosis risk stratification and start them on medications early. So this is kind of the score, and it's on MDCalc, like I said, and this is the scoring system. I'm not going into great detail, but if anyone's interested, definitely look it up. So basically, if you can add a statin, or if you can add a GLP-1 or something like a pioglitazone, or refer them to bariatric surgery early on, we can kind of catch these comorbidities early on, and most likely stratify their MASLD. That's the key idea. That was something we learned. And another interesting thing was comparing physician. There was a lot of AI sessions, so definitely something that's nothing new for us, but they kind of compared physician and AI chatbot responses to patient questions posted on a public social media forum. And interestingly, what they found was proportion of responses rated empathetic was higher for chatbot. So it's about 45% higher compared to 4% in physicians. So we definitely have to up our game, or AI is going to take over, okay? So this is something he's going to talk to us about, the early career forum that we had during the first day.
So for my part, in my journey for endocrinology, I did not know when I was born that I wanted to be an endocrinologist. Second year, first month, I had an endocrinology rotation with Dr. Panja. I really enjoyed myself. And so I asked him how I could get more involved in it and figure out what to do. So he told me to try for endo. When I applied, they sent me an email following up saying, hey, it's your first time. Do you want to be considered for the early career forum? My first question is, what is the early career forum? And so they didn't tell me much. They just said, come by. It's the day before it starts. And hey, if you submit a letter from your mentor, Dr. Panja, great guy, highly recommend. Please refer your patients to him. We could probably fit you in, and you'll get award for it. And I got a monetary stipend as well, and it was okay. When we went there, I did not expect what I saw. It was basically the entire leadership of the conference in a room with 100 of us, and they introduced themselves, very down-to-earth people, and they basically broke down endocrinology as it is in the US and abroad. So we had the entirety of the leadership of all the research journals that we have, and some of them are still like on last month's issue. He was on the cover, and I met him there, and we talked, and he gave me his email and everything. So it was a mystery to me when I started off what to do. And for my part, I would look at a patient's chart, see an A1C of 11 and say, absolutely not, and then just start working on their insulins. But then they taught me that there's different branches of endocrinology, whether you want to do clinical, which I'm interested, or academic, or work in locum, or work in academics like Dr. Raghavan does. And it really helped. And as the day progressed, they went on to break down how to manage fellowship match, how to manage looking at different programs, what to look for, how to set up your resume. And these are people who've been working for decades in endocrinology, and they're coming to the next generation, introducing themselves and trying to help us progress. So if anybody's even a little bit interested, I highly recommend. This year's is going to be in June.
San Diego. Yeah, in June.
In San Francisco. San Francisco. So Yeah, and we do have a couple projects in the works, so we could definitely set up a poster presentation for y'all and go from there. And I highly recommend, getting in touch with an endocrinologist, getting a letter of recommendation. And it's only sending a letter of recommendation when the applications open up and we can go to the conference a day early, get in touch, network, work on our resumes, and really plan on our future.
Yes, so I found this very interesting. Met a doctor there. Her name is Malini Gupta. So medicine doesn't have to be always boring. She's an artist, and she was very much interested in vegetable and food carving. So this is what she does now. She's a blogger. She does this for a living now. She does this for big corporations. I think I'm not sure which one, but I think AstraZeneca. She has a contract with them. She does illustrations for them out of things from the kitchen. So medicine doesn't have to be boring. Please find time to do things you're interested, not just reading and going to conferences. Thank you.
All right.
Hi, everyone. Hope you're all doing well. So this June, 2 months ago, I went to the ASCO conference, which stands for the American Society of Clinical Oncology. So I'm going to talk a little bit about that. Okay, so this is an annual meeting. It's a really big meeting. There are oncologists worldwide that come. This year, there are 46,000 people in total who came. But majority of them were not actually oncologists. Majority of them were like pharmaceutical representatives, sales reps, stuff like that. Only like 37% were oncologists. So it's not, only oncologists, it's, everyone part of the team who goes there. So it was really big and it was a bit overwhelming, but it was nice. So the main purpose of the conference is kind of, go over the different clinical trials, networking and seeing what are the new updates in oncology, and putting them all in one place. Yeah. So I'm going to talk about some of the three main abstracts that really kind of groundbreaking over there. The first one is for lung cancer. So in lung cancer, in stage 3 lung cancer, that's kind of unresectable. Usually the standard of care is giving you adjuvant durvalumab, which is a kind of immunotherapy. But now they have this new drug, osimertinib, which is kind of like the erlotinib kind of sister drug. And it's kind of for EGFR mutated non-small cell lung cancer. And it showed a significant improvement in median progression-free survival. So in the standard of care, which is usually the durvalumab, patients' median progression-free survival was 5.6 months. But with this drug, it was 39.1 months. So it's a huge difference in median progression-free survival, and improving overall survival too. So that was really a good, interesting thing. Yeah. Another one was for breast cancer. Breast cancer, unfortunately, there weren't that many good updates. There was a drug called sacituzumab, which was like being hyped up a lot since 2020 by the drug companies, and everyone was expecting it to be a really good drug. But unfortunately, the trial ended this year and didn't show any good, benefits in overall survival. So this other drug, T-DXd, trastuzumab deruxtecan, is part of the DESTINY trial. So this drug, basically, T-DXd, you have the trastuzumab, and then you have chemotherapy attached to it. So it kind of targets the malignant cells directly with chemotherapy. So it's like less systemic toxicity and, directly going to the tumor cells. And they tested in HER2 low and HER2 ultra low patients. So generally speaking, you consider someone HER2 positive if they have more than 20% of their cells have the HER2 receptor. And so in these patients, usually you wouldn't give trastuzumab, but this study showed that you can give trastuzumab in patients who have HER2 low or ultra low, so around 10% HER2 positivity, and it showed a good, not a bad, improvement. So patients who did get it had 13 months progression-free survival, and patients who didn't get it had 8 months progression-free survival. So it wasn't too bad compared to it was kind of modest improvement. Yeah. And the last one for GI cancers with esophageal cancer was a pretty, groundbreaking study. There's something called the FLOC protocol, which is 5-FU, leucovorin, oxaliplatin, and taxotere. And they compared it to the standard of care, which is CROSS protocol, which is oxaliplatin and taxotere by itself. And it showed that a significant difference, 66 months versus 37 months in survival, which is 5 years versus 3 years, which is a pretty good benefit. So that was also a pretty groundbreaking trial, and it's being incorporated a lot in the standard of care, and from now on. And then lastly about Chicago, it was a good trip. I was there for 3 days. It was I had my step 3 right after the conference, so I didn't really get to enjoy Chicago that much. But it was a really good experience. The conference itself, it was really big. It was really overwhelming. I don't know if I would go again. It was it's good to go once in your lifetime and to see it, how big it is. But in terms of networking and learning, I didn't think it was that beneficial because there's just so much, and you're at the same time you have 3 different conferences going on within the same hour. So it was kind of hard going back and forth and seeing 2 different meetings and learn and everything. So in terms of that aspect, I wouldn't really recommend it, but it's definitely something to see once in your lifetime. It's so big. There's so many different vendors, a lot of free foods. It was really fun in that aspect. But yeah, that's pretty much it.
I don't think Dr. Garnapudi will make it today, so. Oh! Man, I think you were on a thing. I was about to cut him off.
I know.
All right.
He has been patiently waiting.
I know.
Sorry, I had to do. You ever had to do a judge thing for medication? Ridiculous. Huh?
What was that? Medication?
The medication was Vabomere. I was trying to get it for one of my patients, and if you guys ever get to the end of appeal process, you have to talk to a judge. Yeah. I've done it twice. All right. Okay. Keep up. Okay. I guess we can go through this. So background and training. I'm actually from here. So from Houston, and I think a lot of you guys knew this. My dad was actually a doctor here whenever the hospital first opened, along with Dr. J over here. So he knew him well.
I knew him when he was knee high.
Yeah. So I did most of my training in Dallas, and then this is actually my first place that I did practice at afterwards. Hobbies, not too much. Maybe video games every once in a while, and playing with my kids. Current roles at HCA, so I do infectious diseases here, you guys know that. I do antimicrobial stewardship, and then I also chair the infection prevention. One thing we may not know about you, no idea. Huh? I'm actually playing college football now because it came back after 12 years, but you guys are probably too young to remember the old one. Which conferences do you go to and recommend? Obviously, Ivy Week is the big one for us. So we have a big week where we have everybody over there. Shay is there too, which is the Epidemiology Society. And we kind of go through, and it's very interactive. It's very entertaining, and it's a whole full week. How do you keep up with literature? Keeping up with literature is tough. I like Journal Watch. So Journal Watch, if you guys haven't signed up for, we'll send you journals every week that's up to date on literature. And it's really an easy way to keep up with the newest kind of primary literature that you get. What is your area of expertise within your field? No, they're all electronic.
You don't get any here help.
I have NEJM. I get NEJM. I get Annals of Internal Medicine. Those are really the only 2 that I get to my house. Everything else I do digitally. I mean, because you even stack up, they end up too many, right?
Journal Watch is published by the Massachusetts.
Mm-hmm. And it's really nice. It sends you.
They give you electronics. never get too much.
Exactly. And then my wife gets mad at me if I have too much trash. So, what is your area of expertise within your field? So I would probably say antimicrobial stewardship. So that's where I spent most of my training in hospital epidemiology. So that's why we do infection prevention and things of those nature. Two, practicing changing pearls in your subspecialty within the past year. What has changed in the past year? Oh, and the Pearl, yeah. So yeah, that one's a bit complicated, but I do have some articles that I was going to go through just to kind of point it out pretty fast. Yeah, there's steroids and severe cap. I have about 4 articles that I was just going to pop up real fast, if that's okay with you, and then we'll go from there. Let me just see if I can hop onto email from here. Can I get onto email from here?
Email? You can get on my email.
Can I get on my email?
Maybe.
Or is it blocked here?
Is it what, Yahoo or something?
Gmail.
Gmail may not work. You're welcome to try.
Otherwise, you know what? I can look it up on my phone and just Google the articles.
Oh yeah, that's fine. No.
Yeah, that'll probably be the easiest way to do it.
Okay. Which one?
Well, I have like 4 of them, so I was going to go through them real fast.
Okay. Any JM? I'm interested. All right, you can go ahead and start. I'll share this thing.
All right. So a few ID articles that I wanted to go through. The first one is Paxlovid. So Paxlovid has gotten really popular now, and it's even gotten more publicity because it's no longer an EUA. So now it's very, very expensive. So people always say, Kevin, do you need Paxlovid or do you not? And I think this was brought up last time. So have you guys seen the newest studies for Paxlovid? So there's actually a few of them. This is the one that came out recently, and really it's about unvaccinated versus vaccinated patients. And we can kind of go to the gists of it. See, there's a nice little here. So what do you guys think about Paxlovid? Do you think it's effective or not effective if you're vaccinated? Huh? It's not effective. So that's why I'm trying to find the graph. So really what this shows is your symptomatology if you're vaccinated for COVID-19 and then you were to get Paxlovid, your actual decrease in symptoms is less than a day. So there are other studies going around now. People are trying to do a 15-day therapy for long COVID. Do you think a 15-day therapy for long COVID prevents it? No, but they say it's safe. So that's one thing. So really, I think what really the juxt of this article is saying is if somebody is vaccinated, you need to be cautious if you were to use Paxlovid, because remember, Paxlovid has a lot of drug-drug interactions. Especially, don't worry about, or especially patients with anticoagulation. So it's really a risk versus benefit. So if a patient is non-vaccinated, probably yes. If a patient is severely immunocompromised, possibly. But if not, it's probably not a drug we need to be using all the time. Through the next 2. All right, and so this one I wanted to go over because this is actually a patient we had here, and I sent to you guys. So this is kind of nice. Who's here? You have the patient. Yeah, so recurrent MSSA bacteremia. So one of the newest things that came out in the last couple of years is actually using synergy with a carbapenem. So the carbapenem we use is actually ertapenem, and it rapidly clears persistent MSSA bacteremia with ANSEF as well as ertapenem. Huh? So they've done a lot of these studies. The French used to do them a lot. Dr. J probably knows more than I do. So what happens is the first antimicrobial binds all the receptors and the second one pushes through it. So why do they use ertapenem as opposed to using other penicillins? I don't know. Previously, actually, if you look at the old MRSA data, you could use ampicillin along with daptomycin or vancomycin and it would work. The reason why they use ertapenem is probably for stability. It's also easy because it's once a day, but there are studies with meropenem as well. But why carbapenems over other beta-lactams? All right, so this is the other one that everybody's going to talk about is doxycycline. Have you guys heard of doxycycline prophylaxis? For STDs. Yeah, so actually the CDC has it. So this is a big thing that you guys should know about. So this is for patients that are at high risk for having STIs, and this is somebody that within the past year has had an STI, specifically syphilis, gonorrhea, or chlamydia. And if they're in high-risk sexual situations, they can actually call you within 72 hours, just like post-exposure prophylaxis, and you can give 200 milligrams of doxycycline. It's quite effective, and the CDC actually recommends it. So this is something you should see in your PCP clinics. Yeah. Yeah. But you have to do it within 72 hours. So, I mean, you can give them repeated doses, and they actually have in their recommendations that you can just call it into the pharmacy and have them pick it up as needed. So if you have high-risk patients, just like you have somebody that's on pre-exposure prophylaxis, you should probably consider giving them doxycycline as well. If they have high-risk sexual encounters, then they can easily take doxycycline or prevent STIs in the future. Yeah. Or even if they come to your clinic, or like I have a lot of patients that call me because I have some high-risk patients, and they'll call me and they'll say, "Hey, Kevin, what do you think about doxy?" And then we'll just call it in and let them do it. And patients are very compliant. So people that are calling and asking for prophylaxis will take it. Otherwise, they wouldn't call, right? Hold on. And then the last one is crab. Everybody loves crab now, right? Do you guys know what crab is? Yes, carbapenem-resistant Enterobacter ACA. So, or sorry, Acinetobacter and Enterobacter ACA. So what is this drug? Have you guys heard about this? Sulbactam, Durobactam? Huh? So this is the big thing that you guys will see now. So Sulbactam has activity against Acinetobacter, right? So that's why we use Unison. We use Unison not for the ampicillin, but for the Sulbactam. So they derived a second one, which is called Darilobactam. And so they did a study where they compared imipenem plus this versus imipenem plus colistin, and it was non-inferior. So if you actually go through the IDSA guidelines, this is first line. So this is one of the big drugs that you guys will be seeing come out in the market. So what's the problems with it? One, it's cost prohibitive. It's about $3,000 per day. And the other thing is the study itself, if you were to go through and read it, it doesn't use standard of care. So what was standard of care before for Acinetobacter? Yeah, it's Sulbactam plus a secondary agent. So you always have to use two. So, yeah, so it's high-dose Unison or Sulbactam plus a secondary agent. So either the secondary agent could be colistin, it could be minocycline, it could be cefderocol. So the issue is this drug was not studied against high-dose Sulbactam because you can't compare Sulbactam to Sulbactam. But it became one of the first-line agents that we're supposed to be doing, so this is something that everybody's going to be talking about, so you guys are aware of it. All right, any questions on anything? Excuse me? You know, I think this considered an orphan drug. Because the gram negatives is where they're pushing. Because if you remember, there wasn't a new gram negative antimicrobial for a long time. Everybody did staph, because that's what you see more often. I think it's like 7 to 9 years. But if it's standard of care, let's say if a patient needs it, obviously you have to give it to them. But the big thing that I would say is most societies are kind of pushing back because they said the study wasn't done properly. Of crab? Oh, it's going up. It's a lot more prevalent. So I can text, let me see, I can text Maya, the infection preventionist, and find out. But I think it's gone up like 300% in the last year. So we're seeing a lot more of it. So I think we have a few in the hospital right now. Yeah, it's almost all hospital acquired, or it's from LTACs or long-term facilities. But you're seeing a lot more of it now. On Candida aureus? So Candida aureus, so you start off with an echinocandin plus a secondary agent. So like amphotericin, and then from there you use secondary echinocandins like anidulafungin. And now they have all these experimental drugs that we're trying to get for that guy. But that's going to be the next one is Candida aureus. Candida aureus, you can kind of think of MRSA in the 80s where everybody's scared of it. For which one? Oh, for this one? It depends on where it is. It's just like any other gram negative. So just because a gram negative is multi-drug resistant doesn't change what it is. So usually 10 days is more than enough. So just because a drug is or bacteria is more resistant doesn't mean you have to treat it any longer. All right.
Okay, I think that's, yeah. Oh, yeah. Discovery series are on top. Oh. Yeah, we can meet whenever.